everyone. Today we'll be discussing and debunking one of the most common myths associated with our specialty, that is oral maxillofacial surgery and dentistry also as well in general. This is the kind of myth that you all must have heard in your BDS life, in your MDS life, and you've been answering this question from the patients for it's like almost like forever. So what is this question? The question is, does extraction cause blindness? The straightforward answer and the most honest answer to this question is no. It does not cause any form of blindness to anyone at all. And today we'll be trying to answer this question in the form of a JC. Now this JC presentation, I'll be also trying to teach a few things as well along with the presentation, along with this PPT and the article that I'm trying to take up. So bear with me. I'll try to suffice this video in as less time as possible. Now, how does this entire thing start? If there were no reports from extraction blindness or post extraction blindness, then how did it start at the first place? The answer is it was not the extraction exactly, but the local anesthesia administration that caused this entire stir. So, why local anesthesia administration? We'll see in this journal. We'll see in this article. So, we are seeing the article by Boyens et al. Boyens et al. Means Boyens and the doctors who along with Boyens co-authored this. So the article's title is Ocular Complications Associated with the LA Administration in Dentistry. This article has been taken up from the journal you have to mention and the DOI you have to mention, that is Dental Clinics North America 2010. Along with that, there is something known as impact factor, which you have to mention while doing a JC presentation. The question is, what is an impact factor? Now, the impact factor stands for the number of times article has been cited in a particular amount of time. So that is defined as an impact factor. For example, if an impact factor is 2.5, or let's say it is for a journal. So if let's say a journal has an impact factor of 2.5, so that means the journal's articles has been quoted or has been cited 2.5 times in respective, let's say, thesis or dissertation or other fellow studies. In that way, I have not given impact factor over here. I want you people to just go through Dental Clinics on North America Journal and find the impact factor for me, and let me know in the comment section what have you found out. Anyways, so we'll move forward. So moving forward into this, so we are going to cover ocular complications, introduction, the most widely used method for controlling pain. We all know local anesthesia is one of the most common methods. But what does it do? Basically, in the vicinity of a nerve, we deposit our LA, and that LA will act on it and cause blockade in that particular region or anesthesia in that particular region, followed by which we can carry out our surgical procedure. Now, if your LA is not deposited in the proper vicinity where we want it to be or in the desired area, then it might go into neighboring areas where we might not need it at all. For example, if we take from our oral cavity only, let's take an example of our oral cavity. There are nearby sites. There are your nearby sites such as parotid, which has 7th cranial nerve, and if you give LA in this region, it will cause same side facial palsy, same side facial palsy. So it is very much important that our local anesthesia administration, the techniques associated with it should be on point, right? Now moving forward. Now if there are some nearby complications, are there some any distant complications also? So this article has started off with the same point that there have been some distant complications noted. What are distant complications? That are not associated with oral cavity, neighboring areas which are not associated with oral cavity but can still have complications are known as. In this article, they have covered about ocular ones. Ocular ones. And the earliest were blurring of vision, blurring of vision, and your amaurosis. And your amaurosis. Amaurosis means temporary blindness. Amaurosis is also a synonym of temporary blindness. So this is one of the earliest noted feature from local anesthesia administration, from improper local anesthesia administration. What else? You can also have mydriasis. We can also have mydriasis, which is also dilation of or dilatation of pupil, which is caused by dilator pupillae muscle. Dilator pupillae muscle, right? Along with that, it will also cause ptosis. Ptosis means drooping of eyelid. Ptosis means drooping of eyelid, and diplopia. Now diplopia is double vision. Diplopia is a very vast topic. We'll cover it in the case of trauma or in one of the JC articles as well. So Horner-like manifestations. Horner is nothing but a Horner syndrome. I hope you can read about Horner syndrome in detail because it's currently a too vast of a topic to cover in a JC. So generally symptoms start immediately after the injection of the anesthetic or last for several hours. Most commonly, symptoms have been noted 5 minutes after and have been commonly noted to last till 6 hours. 5 minutes to 6 hours. That have been the most common duration while which symptoms have been noted. Now moving on to the most important part, that is clinical reports and implications. So whenever you're presenting a JC article, the author must have quoted different articles or scientific articles from different journals and different studies. So in this case, we'll take another pen. 1962 Cooper study. What is the Cooper study? So what did Cooper do? Cooper basically he took mepivacaine. Cooper took mepivacaine. Mepivacaine. That is 2% mepivacaine plus your adrenaline, and he injected. And he injected. So in those cases, he noted in about 48 case reports, and in those cases, he noted that there was diplopia, there was your ptosis, there was blindness also, or also called as loss of vision. And he did this study in 48 patients and he noted all these features. Now the question was, he was a bit confused at how all these things happened at the first place. In out of these 48 people, most of the people had two symptoms. At least two symptoms they showed up. So he got a lot confused after this. Next study they quoted is Blixter and Britton in followed by 1975. Now in this study they noted that most of the injections were more predominantly associated with maxilla rather than mandible. More commonly associated with maxilla rather than mandible. How many? 42, 39. 42 and 39. This was given by Blixter and Baxton. And also what they noted was this thing is spreading in a retrograde pattern. Now Blixter and Britton were not sure about their findings. So they told that local anesthesia might be traveling in a retrograde pattern through the vessels and might cause these things, but they were not very sure about this. So followed by which in 1957 Walsh gave a very important study of his own. Walsh told that there was permanent blindness in his patients. There was permanent blindness along with procaine adrenaline solution. So patients started with a sensation of, let's say, blue color, followed by which there was continuous loss of visual acuity, and there was retinal damage. And loss of visual acuity. It decreased to the point of permanent blindness or permanent loss of vision. So finally, an important study was done in 1957 itself. Sorry, not in 1957, but in 2011 actually, not in 2001. So this study accumulated all the studies from 1957 to 2001 to see how many complications have been happened, and it reported 48 cases. It reported 48 cases. Now these 48 cases, out of which 27 were maxillary and 21 were mandibular. 21 were mandibular with female predilection. With female predilection. Now 40 reports, 83.3% have transient manifestation that disappeared within 6 hours. This is a very important point. Followed by which was the most commonly noted? Which was the most commonly noted? The most commonly noted was ophthalmoplegia, that is muscle paralysis. Muscle paralysis was the most common symptom of your blindness or ocular complication, was the most common complication in this table. If you guys note ophthalmoplegia, then ptosis, mydriasis. Now in the decreasing order we can see these complications have been noted. So most common complication was muscle paralysis. Now some studies were done about the type of agent that is associated. So it was found out that RTK is associated has an increased association with all these complications. Why? Because of increased diffusion nature. Increased diffusion nature, RTK was commonly associated with all these ocular complications. So what exactly is the etiology? So what exactly is the etiology that is causing all this? Etiology. Now etiology was attributed to arterial, venous, myofascial planes and sympathetic ganglion anesthesia. So we will look at it. Let's say arterial. So what they told in arterial was, first of all, in arterial some features were very common, that is temporary dizziness, blanching of skin, followed by anesthesia of eyelids, followed by some more features, anyways. These were the most commonly features noted. And why was this happening? Because of reduced supply to lacrimal nerve. Lacrimal nerve is supplied by an artery known as lacrimal artery. Lacrimal artery. So what people told was, because of the improper technique, because of the improper technique due to arterial injection of LA for extraction, it enters into the artery. From artery it goes to lacrimal artery. From lacrimal artery it diffuses to lacrimal nerve, and it causes these complications. But the question comes, how? Which artery it is diffusing? So we will look into it. Most common was maxillary artery. So forced injection into maxillary artery causes retrograde flow. From maxillary it goes to middle meningeal artery, and from middle meningeal it anastomosis. Now middle meningeal has been shown to anastomos with lacrimal artery in a lot of cases. That causes LA diffusion followed by lacrimal nerve anesthesia. Followed by lacrimal nerve anesthesia. Now once lacrimal nerve gets damaged, what it does is it also lacrimal artery also causes damage to abducent nerve, and that's why lateral rectus gets affected. Your lateral rectus gets affected, right? So this is one of the most common causes. This is one of the most common causes, that is the arterial cause that we have just studied. Now we'll look into the now we'll look into venous cause. Now we'll look into venous cause. Venous causes. Now what is venous causes? Now venous causes theory says that instead of artery, you have gone into alveolar vein. Inferior alveolar vein. And that inferior alveolar vein goes into PVP, that is pterygoid venous plexus. From pterygoid venous via help of emissary veins, it goes to cavernous sinus. And now you should know that in one of the lectures that we recorded, we talked about third, fourth, and sixth cranial nerve and their course. That was a brief overview. And if you remember, third and fourth were going through the wall, but sixth was the only cranial nerve, because we all have watched it very properly. Sixth cranial nerve is the only cranial nerve which goes through the cavernous sinus, so anesthesia inadvertently travels to sixth cranial nerve, once again affecting your lateral rectus and muscle paralysis. One another theory that was given was a theory of myofascial planes. Was a theory of myofascial planes. Now, what does this theory say? What does the theory of myofascial planes say? They say that which is often considered as a cause of anesthetic failure, that anesthesia always travels in the path of least resistance. Now, many of you might have heard this question in your, let's say, clinical postings, or even in your PG life also, that what is the desired area? What is the target area? Why do we talk about a target area? Because when you are dealing with tissues, there are different planes in which tissues exist, and having your LA deposited in the right plane is extremely important. Because if you deposit in a different plane where it will have a different area of least resistance, LA will go into a different area altogether. So what happens was, if you deposit in the wrong area, let's say if you're giving an infraorbital block, or you're giving a maxillary block, and it goes into a path of least resistance, that is not the target area. So what it does is, it goes and flows towards the orbit. It goes and flows toward your orbit. And this has been proven by radio-opaque dye studies. Radio-opaque dye studies have proved that your LA gets diffused to orbit along the path of least resistance during forceful injections. So even though solution was deposited, let's say 2 centimeters or even further, these radiopaque dye studies have proved that it might go entirely into a different region, and can also has been shown to also diffuse towards orbit, hence causing your nerve anesthesia. And the last cause that is associated is, and the last cause that have been told to associate is, okay, let's take this one. is known as sympathetic ganglion anesthesia. Now, in my lecture from Cranial Nerve Introduction or Neuroanatomy Introduction, I told about something that you have a craniosacral outflow, that is parasympathetic nervous system, and then you have a thoracolumbar outflow, that is sympathetic nervous system. Now, sympathetic nervous system is nothing but from T1 to L2. So you have a spinal cord, and outside all spinal cords from T1 to L2 segment, you will have an extra ganglion. And these ganglion are known as sympathetic ganglions. So anesthesia of these ganglions have been shown to cause something known as Horner-like manifestations. Horner syndrome is nothing but ptosis, mydriasis, and all those clinical features, which we'll not talk about in detail, but they cause Horner-like syndromes. Along with that, what they do is they cause dilatation of your pupil, that is mydriasis only, hoarseness of voice, and it is all associated with stellate ganglion block. Stellate ganglion is one of the cervical chain of sympathetic nervous system. It is one of the cervical ganglions of sympathetic nervous system, right? So these features have been associated to be cause of etiology, as supposed to be causing the etiology of etiology of ocular complications. Moving forward, if you look at this diagram, which is not that clear, I beg your pardon for this, but this is an anatomical relation, and over here, if you note, I'll try to reduce the pen size also. Now over here, if you note, you deposit your injection somewhere here. From here, let us inferior alveolar vessel, the injection is going up, and along with it went to maxillary. From maxillary, it went to middle meningeal to went to lacrimal, and this is the course we were talking about. It is affecting the eye in this way. So now we know that our LA can not only travel into, let's say, neighboring areas, but also distant areas, and one of the most important regions is vision or eye. That is why it is very important that you give LA with. Now, what are the proposed causes of ocular complications with maxillary injections? Now, it is, as you can already see, that maxillary injection have a more common predilection compared to mandibular injections. The question is why? So let's talk about maxillary injections. Well, let's talk about maxillary injections. So in case of maxillary injection, first cause that has been noted is diffusion, is known as diffusion. So as opposed to mandibular injection, in which injection, now if you look at it, mandible injections are much more further from your orbital area, but maxilla is very nearly located. Like tell you have your infratemporal fossa behind the maxilla, inferior orbital fissure, and then you are in the orbit. So if you know that the maxillary area is extremely close proximity, so diffusion is one of the common causes. If LA is deposited in, let's say, PVP area during a PSA injection, it can due to diffusion into pterygomaxillary fossa, can reach orbit, and once it reaches orbit, it can cause the ocular complications. Similarly, there have been some arterial causes also. In the arterial causes, it is then been noted that if you directly go into, let's posterior superior alveolar artery, then you will have a retrograde flow, which we have already talked about, to your mid-meningeal IMA, sorry, first IMA, then middle meningeal, and from middle meningeal it will go to lacrimal artery and will in turn form the ocular complications. Venous complications in the case of maxilla are associated with venous with PVP, that is pterygoid venous plexus, emissary veins, cavernous sinus. Now, there is this one study that we need to know. One study was done by a scientist, by a researcher known as Himmelfarb in 2000, where he told that through the inferior orbital fissure, during an injection in molar region, approximately up to 2.5 centimeter of needle insertion, your inferior orbital fissure the needle reached and LA got deposited directly over there, and this caused ipsilateral diplopia. All the condition resolved, but in these cases it is very important that whenever you are evaluating the reports of ocular complications occurring with LA injections, the proposed causes of the event are very variable, and even in literature there have been controversies, but these complications are very rare. First of all, are very rare. So if a patient asks any of your clinical practice, you do not always need to be very true about this, not in the sense true, but you can clearly tell that there are chances in very rare individuals, right? So so hence we know the theory of diffusion is one of the most commonly accepted theory causing ocular complications. So hence it is told that while giving LA, you have to be very careful and especially very slow. LA should not be forced. LA should not be given with in an improper area. Your technique should be sound. So prevention and treatment. Prevention Lee and Bill have suggested the following manner: reassure the patient, continue the monitor vitals, cover the affected eye with protective gauze so that there is no form of drying. Monocular nuclear vision is restored by covering the affected eye, and patient should be escorted. If they last more than 6 hours, then you have to refer to ophthalmologist, and we have to continue our regular follow-up procedures. In discussion, generally when you have a JC, you have to discuss a few articles. Now this article itself is one of the most cited articles, and it has two or three more articles that were found relevant, so I'm not going to discuss them in very much detail, but there have been reports, and most of the have been case reports rather than proper scientific studies that have been done. So hence I'm going to conclude my first JC video. I hope much of the concepts were very easy to understand and were very clear. I have already given a brief overview of much of the relevant anatomical structures. So if you have not seen those, I seriously recommend please watch those videos. You will get to know and you will understand a lot of this JC videos as well. So with this, I would really welcome all the suggestions and all the forms of improvement that I can do. There will be soon a next JC video. We'll be covering a very interesting topic of hiccups as a complication after dexamethasone injection. So this is going to be our next JC topic, and hiccups have been also associated with G administration as well. So many of the times you will be seeing your patients in your wards and everything. The patient might complain about hiccups. So it's important that we should be aware of these little things. I am taking a few simple topics at the beginning so that it does not intimidate anyone. Even the postgraduates should be aware of these basic things first. Then we'll go on to some different kind of topics and some seemingly complex topics. Till then, thank you. Keep learning. Stay curious. Bye.